Hey, pediatric crew, let's talk about the mind behind the medicine.
Today, yeah, we're diving deep into pediatric mental health disorders and the really crucial care that goes with them.
We've got a pretty comprehensive guide here. Seems packed with essential insights.
Absolutely. Think of this deep dive as us, well, unpacking that guide together, pulling out the key knowledge you really need to understand, recognize, and, support kids and adolescents facing these challenges.
And right off the bat, this material hits you with some pretty stark numbers. Just how common are these issues?
The statistics are, well, they're sobering. Nearly 20% of kids in the U.S. have a mental health disorder causing at least mild functional impairment.
20%. Wow.
And then you've got between 5 and 9% experiencing extreme impairment. That's millions of young lives really deeply affected.
It really puts things into perspective. And the treatment gap, that's
Yeah.
huge too, right? This guide notes something like 60% of adolescents with depression aren't getting any treatment.
60%, yeah. And that gap, it can have absolutely devastating consequences. One number that really stands out is the suicide attempt to death ratio in U.S. youth. It's roughly 25 attempts for every one death.
25 to 1.
And tragically, a young person dies by suicide about every 11 minutes in the U.S.
Ugh, it's hard to hear those numbers, but it really underscores the urgency, doesn't it?
It does. And it's not just the child who's affected. This impacts the whole family system. The guide mentions the grief caregivers feel, sort of mourning the loss of their perfect child or the future they'd imagined.
That emotional weight must be immense.
Absolutely.
Okay, let's maybe start by understanding the landscape a bit better. How does this guide define mental illness in kids and teens?
It describes it as um, alterations in thinking, mood, or behavior that are associated with distress and/or impaired functioning. So it's not just, a bad day.
Right, it's impacting their life.
Exactly. Affecting their ability to function day to day.
What's interesting is how it emphasizes the complexity. Like, what's considered normal behavior changes so much depending on the kid's age, right?
Totally. Normal varies wildly, and mental illness just doesn't look the same in a 5-year-old as it does in a 15-year-old. That developmental age piece is absolutely critical.
And speaking of development, the adolescent brain, that's a huge factor mentioned here, still developing until the early 20s.
Yeah, very much a work in progress. Significant rewiring happening, especially around puberty.
Mm.
It explains a lot about the intensity of those teenage years.
It really does. So why do these conditions develop? The guide talks about etiology, the origins. It sounds like it's usually not just one thing.
Rarely one single cause. It's almost always a complex mix. You've got the genetic piece, multiple genes interacting with the environment.
So family history matters for things like depression, anxiety, bipolar.
Right. And some conditions, like autism or ADHD, seem to have a particularly strong genetic link, according to this guy.
Okay, genetics. What else?
Then you have psychological factors, things like major stressful life events, the child's individual personality or temperament, even gender differences pop up. Depression seems more common in girls, ADHD often more in boys, and age, of course.
And the environment they're in, social factors.
Huge, both as risks and protective factors.
Mm-hmm.
Parental support, how they're doing at school, socioeconomic status. The guide specifically calls out multi-generational poverty as a big risk factor.
Mm.
Culture and religion can play a role too, sometimes protective, sometimes maybe a barrier to getting help.
Yeah.
Strong relationships, friends, family, those are major buffers.
And under the surface, there's the neurochemistry, brain chemicals.
Yes, absolutely. Deficiencies in chemicals like norepinephrine can mess with attention, memory, mood. Serotonin is linked to anxiety, obsessions, compulsions. Dopamine impacts pleasure, motivation, thinking.
Yeah.
It's this incredibly intricate interplay inside the brain.
So pulling all that together, what are some of the key risk factors this guide flags, things that make a child more vulnerable?
We're looking at things like existing physical health problems or intellectual disabilities, low birth weight, definitely family history of mental illness or addiction, that persistent poverty we mentioned, and tough experiences like caregiver separation or abuse or neglect.
It links back to those stats we started with, doesn't it?
Yeah.
Lots of kids undiagnosed, undertreated. The guide mentions primary care providers might not always have deep expertise here.
Right, and there's often a link between untreated mental illness and risky behaviors later on. Suicide tragically being the most severe consequence.
Which brings us back to stigma, reducing that stigma, making it okay to ask for help. That seems essential.
Absolutely vital.
Okay, so moving from understanding the why and what to actually, recognizing signs and assessing a child. How do we approach that?
Well, the guide really stresses that assessment is never just about the kid in isolation. You have to look at the family context, their social world, cultural background, and crucially, their developmental stage.
It's the whole picture.
Exactly. Evaluating all those biological, social, and psychological threads together.
A core tool mentioned is the mental status exam. That sounds kind of formal.
It can be, but it's really about keen observation as much as asking questions. You're looking at their appearance, how they move, their behavior, how they interact socially.
Getting a sense of their thinking, too. Memory, attention span.
Yeah, memory, orientation, attention, comprehension, their speech and language, and understanding their mood, their feelings, their insight into their problems, their judgment, and importantly, their thought processes and content.
And that includes asking about some heavy stuff. Hallucinations, self-harm.
Yes, you have to assess for those things directly. Auditory or visual hallucinations, any delusional thinking, signs of self-harm, substance use. It gives you a vital snapshot of how they are right now.
And the history taking sounds crucial, too.
Paramount. Why are they seeking help now? What's their psychiatric history, general health, medications? How have they coped with problems before? Developmental history is key attachment, temperament early on.
And risk assessment is a big part of that history.
Oh, absolutely critical. Asking directly about suicidal thoughts or thoughts of harming others. Do they have a plan? What means do they have access to? How legal is the plan?
You have to ask those direct questions.
You do. And also about past aggression, setting fires, running away. And here's a really practical, potentially life-saving point from the guide. If a child shares a plan and has the means, like pills at home or access to a weapon, the nurse has a responsibility to work with the family and others to eliminate that access immediately.
That's direct action, taking those means away.
It's a crucial safety intervention.
The guide also tries to differentiate between, like, normal kid stuff and something more serious, right? Tantrums versus something needing evaluation.
Exactly. Common issues like temper tantrums, maybe some school avoidance, dealing with grief, those are often part of growing up. But persistent defiance, really disruptive tantrums, constant arguing, physical aggression, especially if it's seriously interfering with life at home or school that warrants a professional evaluation.
And ruling out physical causes first, that seems important.
Absolutely. Before jumping to a mental health diagnosis, you've got to consider, could this be an underlying medical issue? A sensory processing problem? A medication side effect? Thyroid issues? Even things like lead poisoning or, rarely, a brain tumor. Check those first.
The DSM-5 gets mentioned as the diagnostic manual, but with caveats for kids.
Yeah, it's the standard guide, but applying it to children has nuances. You often see high comorbidity kids meeting criteria for several things at once. And because kids develop so rapidly, someone diagnosed at one point might not meet the same criteria a year later. It's dynamic.
So, okay, let's say there's an assessment, maybe a diagnosis. Where does care actually happen? What does it look like? The guide lists a whole range of settings.
Yeah, from school counselors or therapists coming to the home to outpatient clinics, group homes, residential treatment, even partial hospitalization or inpatient units for more acute situations.
And therapies. Psychosocial therapies are highlighted.
Very much so. These therapies help kids identify and change problematic thoughts and behaviors, and importantly, build coping skills. They can be effective on their own or sometimes used alongside medication.
Therapy with kids must be different than with adults.
Oh, definitely. The guide points out you need to help them prepare for the future, develop self-awareness, and recognize that kids often communicate a lot non-verbally. You have to tune into that.
So the goals are things like improving communication, building self-esteem.
Yes, stimulating healthy development, expanding their emotional vocabulary, helping them process tough or traumatic events, and gaining some emotional distance from painful experiences. It's about growth and healing.
And making it engaging. The guide says therapy works best when kids have fun.
That's a key insight, making it enjoyable, letting the child have some control when appropriate. That really helps them engage.
So what types of therapy are mentioned?
Well, there's play therapy, art therapy, music, pet therapy, great for nonverbal expression. Then more structured approaches like CBT, cognitive behavioral therapy, which helps connect thoughts, feelings, and actions.
And DBT, dialectical behavior therapy.
Right, DBT is mentioned as being pretty intensive and structured, especially helpful for kids with significant emotional instability, self-harm, or suicidal behaviors.
And the tools they use sound very kid-focused. Games, crafts.
Exactly. Animals, worksheets, behavior charts, timers, videos, music, even sensory tools like weighted vests or body socks. visual supports, whatever helps the child connect and process.
Okay, what about crisis situations? The guide talks about crisis intervention.
Right. A crisis is defined as a time-limited incident that feels overwhelming to the child. There are four main concepts the guide highlights for managing these moments.
Okay, what are they?
First is safety, always. Patient safety, staff safety. Second is catharsis, allowing, even encouraging the child to express those intense feelings safely.
Letting it out.
Yeah. Third is empathy-based listening. Really trying to understand their perspective, using phrases like, help me understand how you're feeling right now.
Not just fixing, but understanding.
Exactly. And fourth is entropy. It's this idea that the calmer the nurse or caregiver remains, the more it can help de-escalate the child. Your calm helps counterbalance their chaos.
That's a powerful concept, staying grounded yourself.
It really is.
Okay, let's maybe touch on a few specific challenges the guide covers in more detail. Stress.
Yeah, stress, it's normal, right? Kids need some stress to learn how to cope.
But some kids are more vulnerable.
Definitely. Factors like their cognitive development still being immature, maybe lack of judgment, stressors at home or school or with peers, big life events, even just the pace of modern life, media overload,
Basic needs not being met.
right? Or anticipating something difficult. All these things can predispose kids to feeling overwhelmed by stress.
And how does that stress show up?
Lots of ways. Physically, you might see headaches, stomach aches, GI issues, even bedwetting or soiling sometimes. Or they get sick more often because their immune system is down.
And behaviorally.
Could be acting inward, isolating, self-harming, substance use, overeating, or acting outward, getting into fights, being defiant. And psychosocially, you see anxiety, depression, irritability, anger.
So what helps? What are the interventions?
Pretty practical coping skills, often. Encouraging exercise, journaling, deep breathing exercises, maybe meditation, or just talking things through with someone they trust. And a key point the guide makes is clinical judgment. Focus on the child's ability to cope, not your own expectation of how they should be coping. Meet them where they are.
That's important. Okay, what about mood disorders? Depression specifically.
Yeah, depression is revisited, that persistent sadness or loss of interest. The guide lists the risk factors again and details how the signs can look really different depending on age.
Like how?
Well, in infants, it might just be a persistently sad facial expression, lack of engagement. In older kids and teens, you might see irritability, changes in sleep or appetite, withdrawal, poor school performance, and in adolescents, sometimes cutting or other self-harm, even suicidal gestures.
And suicide. The guide is very clear that this is a real risk, especially in mid-teens.
Absolutely. It discusses potential motivations, maybe wanting to die, sometimes wanting to hurt others, often wanting to escape an incredibly painful situation like intense bullying or abuse, or even punishing themselves.
But there are deterrents too, things that protect kids.
Yes, strong family support, feeling safe from bullying, which is huge, and having a sense of hope for the future. The guide even uses the term bullycide for suicides directly linked to bullying experiences.
Wow. Okay, shifting to anxiety disorders. These are common, right?
Most common psychiatric disorders in kids, according to this guide. And in younger children, anxiety often comes out physically, those headaches, stomach aches again.
Traumatizing, yeah.
Exactly. And chronic anxiety isn't harmless. It can have real long-term health consequences.
Interventions sound similar to general anxiety management, staying calm, relaxation techniques.
Yes, the basics apply. Staying with the child during acute anxiety, using a calm, reassuring approach, teaching relaxation. The guide briefly mentions specific types too. OCD with obsessions and compulsions.
Rituals.
Right. Phobias intense, irrational fears leading to avoidance. Panic disorder with those sudden, overwhelming panic attacks. Feelings of dread, physical symptoms. And PTSD following a trauma with flashbacks and triggers. It notes being cautious about triggering flashbacks when working with kids with PTSD.
Any specific intervention tips mentioned, like from OCD?
Yeah, for OCD, the initial advice is often not to interrupt the rituals abruptly, as that can spike their anxiety. Better to work on strategies gradually. For panic attacks, the key is staying with the child, providing simple, clear directions and reassurance.
Got it. What about ADHD, attention deficit hyperactivity disorder?
This is defined by those three core symptoms: inattention, hyperactivity, and impulsivity. And the key is that these behaviors are pervasive. They happen in multiple settings and are inappropriate for the child's developmental level.
And it can look different depending on the main symptoms. Inattentive versus hyperactive.
Exactly. Predominantly inattentive type. Maybe seems like they're not listening, struggles to finish tasks, loses things all the time, easily distracted, forgetful. Predominantly hyperactive, impulsive type. constantly fidgeting, squirming, running, or climbing when inappropriate, talking excessively, interrupting, can't wait their turn.
The guide also mentions other challenges that can come with ADHD, like discipline issues.
Yeah, issues with discipline, sometimes difficulty regulating emotions. They might have narrow emotional range or quick shifts, problems with sequencing tasks, processing information efficiently.
So, support involves therapy, behavior management.
Right. Therapy, specific behavior management strategies, and crucially, family support and education. School interventions are also vital things, like preferential seating near the teacher, using clear schedules and routines, breaking down big assignments into smaller steps, minimizing distractions in the classroom.
Makes sense. Okay, autism spectrum disorder, ASD. How is that described?
ASD is presented as a broad term that now includes previous diagnoses like classic autism and Asperger syndrome. It's characterized by severe and pervasive impairment in social skills, communication, and emotional connection, often alongside restricted or repetitive behaviors and interests.
And it's becoming more common.
The guide notes it's the fastest growing pediatric disability, often becoming apparent by around 18 months of age. The essential features are those core challenges in social interaction and communication, plus those restricted repetitive patterns of behavior or interest.
Interventions focus on early support?
Yes, early intensive intervention is key. Family involvement is huge, creating structured and predictable environments, direct social skills training. And sensory processing disorder often co-occurs with ASD, so interventions for sensory sensitivities like gradual exposure, using weighted vests, noise-canceling headphones are often needed.
Right. And finally, under specific challenges, substance-related disorders.
A major concern. The guide points to high rates among youth, and the really alarming fact that drug overdose is a leading cause of accidental death for young people, with opiates being a major driver.
It defines a lot of terms here: use, dependence, abuse, addiction.
Yeah, key definitions are laid out. Use, dependence, needing it to function. Tolerance, needing more for the same effect. Abuse, use causing problems. Addiction, compulsive use despite harm. Withdrawal, symptoms when stopping. And even codependency, unhealthy relationship patterns around the user.
What are some signs to look for?
Things like increased absenteeism from school or activities, unexplained injuries, becoming more isolated or secretive, sudden disappearances, plus physical signs like tremors, flushed skin, changes in pupils. The Gauge questionnaire is mentioned as a quick screening tool.
And asking about peer and family use is critical.
Absolutely critical, the guide emphasizes. Those are major risk factors. Interventions involve discussing consequences honestly, education about risks, instilling hope for change, therapy, individual, family, group, 12-step programs, sometimes non-use contracts. And vaping gets a specific mention. Its high prevalence among teens and the associated health risks.
Okay, that covers a lot of specific challenges. Let's shift gears slightly to talk about medication. This guide has two main rules.
Yeah, two important ones. Skills before pills, meaning try therapeutic interventions first, and start low, go slow when medication is used.
Because using these meds in kids is complex.
Very complex. The effects aren't always as well studied as in adults. Many uses are technically off-label, meaning not specifically FDA approved for that age group or condition. And there's a really critical safety warning about a potential increase in suicidal thoughts or behaviors, especially when first starting antidepressants. Needs close monitoring.
So what types of meds are covered? Antidepressants.
Yes, SSRIs, selective serotonin reuptake inhibitors, are often the first-line choice for depression and anxiety. But you need to monitor for side effects, GI upset, maybe sexual dysfunction, headaches, and more serious, though rare, things like serotonin syndrome or serotonin discontinuation syndrome if stopped abruptly.
Mood stabilizers, like a lithium.
Right, lithium is mentioned for a bipolar disorder, but it requires careful blood level monitoring because the therapeutic range is narrow and toxicity is a risk. You need to watch for signs of toxicity. Divalproeps, sodium, and clonidine are also mentioned, often used off-label for bipolar symptoms or aggression.
And antipsychotics, those sound serious.
They are potent medications, usually working by blocking dopamine receptors. They come with risks of significant side effects. One group is extrapyramidal symptoms, or EPS.
What does EPS look like?
It can include things like akathisia, intense restlessness, dystonia, muscle spasms, like a stiff neck or eyes rolling up, akinesia, slowed movement, pseudo-Parkinsonism, tremors, shuffling gait. The guide mentions looking for a thick-feeling tongue, stiff neck, eyes looking up involuntarily as key signs.
Other serious risks with antipsychotics?
Yes, tardive dyskinesia, TD, which involves involuntary movements, often of the face and mouth, and can be permanent. Neuroleptic malignant syndrome, NMS, a rare but life-threatening reaction. The guide suggests using the FEVER acronym, fever, encephalopathy, vital sign instability, elevated enzymes, rigidity, to remember signs. And metabolic syndrome, increases in weight, blood sugar, cholesterol, blood pressure. So lots of monitoring needed: vitals, weight, maybe ECGs, specific blood levels for some like clozeral.
Okay. Stimulants for ADHD?
Yeah, common side effects are decreased appetite, weight loss, trouble sleeping. Sometimes DICs can emerge or worsen. Rarely, psychotic reactions can occur. They're usually given daily.
And anxiolytics for anxiety.
Many common ones, like benzodiazepines, can be addicting, so they're usually reserved for short-term crisis use. Buspirone is noted as a better non-addicting option for longer-term anxiety management. And SSRIs, the antidepressants, are also very effective for chronic anxiety. With anxiolytics, you monitor for sedation, potential for addiction, and again, suicidality.
So the nurse's role with meds is huge. Education, monitoring.
Absolutely. Thorough education for the child and the family about the med, why it's needed, potential side effects, monitoring compliance, are they actually taking it, tracking vital signs, actively assessing for all side effects, especially the serious ones we discussed, specifically monitoring for any increase in suicidality, particularly with those antidepressants, and coordinating blood draws for levels when needed. It's comprehensive support.
Makes sense. The guide also touches on some other critical care areas, like inpatient care.
All right, inpatient psychiatric care is usually for situations where a child poses an immediate, serious risk to themselves or others. A key concept there is the therapeutic milieu.
Therapeutic milieu. What's that?
It's basically creating a structured, safe, and therapeutic environment. It's not just warehousing kids. It involves scheduled activities like group therapy, community meetings, psychoeducation, balance of some unstructured time for observation and interaction. The whole environment is part of the treatment.
And safety is paramount in that setting.
Absolutely top priority. Personal safety for staff and patients. Checking belongings carefully when admitted for any dangerous items. Checking on patients frequently every 15 minutes is a common standard, sometimes even one-on-one constant observation. Being mindful of everyday objects that could potentially be used for harm. Staff maintaining professional boundaries, not sharing personal info.
And restrictions. Sometimes kids need specific limits.
Yes, different levels of restriction based on risk, suicide precautions, assault precautions, elopement, running away, risk, maybe boundary restrictions. Interventions match the restriction, like one-on-one observation for high suicide risk, maybe a room near the nurse's station, no roommate, careful monitoring of exits.
What about things like restraints or seclusion?
The guide is very clear. These are absolute last resorts, only used when there's imminent danger and less restrictive methods have failed. The emphasis is heavily on prevention.
How do you prevent needing them?
By being aware of a child's trauma history, developing safety plans with the child when possible, using comfort rooms or sensory modulation techniques, clear communication, and skilled de-escalation strategies. The guide also honestly notes the potential downsides of inpatient stays, kids sometimes learning negative behaviors from peers or even experiencing violence from others on the unit. It's a balance.
Another really tough area is childhood abuse. Mandatory reporting is stressed.
Absolutely. Nurses are mandatory reporters. If you suspect abuse or neglect, you are legally required to report it. The guide outlines different types: sexual, physical, verbal, emotional, and gives key signs to watch for.
What are some signs of sexual abuse mentioned?
Things like unexplained bruises, bleeding, or pain in genital or anal areas, STIs, new onset of bedwetting or soiling, and uresis syncopresis, sudden sexualized behavior or knowledge beyond their age, being easily re-traumatized by seemingly unrelated events, new physical complaints like headaches or stomach aches, sleep problems, withdrawal or clinginess,
And physical abuse signs.
unexplained bruises, welts, or lacerations, especially in areas usually covered by clothing, marks shaped like objects, belts, cords, bite marks, bald patches from hair pulling, significant changes in behavior like sudden aggression or being overly fearful or withdrawn around adults, or sometimes being overly eager to please or indiscriminately affectionate toward strangers.
Munchausen by proxy is also mentioned briefly.
Yes, where a caregiver fabricates or induces illness in a child for attention. The guide notes camera monitoring might be used in hospitals if this is suspected. Recommended support after abuse involves ensuring the child's immediate safety and stability, providing specialized therapy, removing the offender from the child's life if possible, and assessing for potential long-term mental health impacts like depression, anxiety, or PTSD.
Okay. Dual diagnosis, what's that?
That's when a child has both a primary mental health disorder and a co-occurring substance use problem. It's quite common.
And treatment needs to address both.
Yes,
Yeah.
simultaneously. These cases often require initial inpatient treatment to stabilize both issues, followed by ongoing outpatient support targeting both the mental health condition and the addiction. Mood disorders, psychotic disorders, anxiety disorders are frequently seen alongside substance use.
And finally, the guide lists some warning signs of relapse for kids with substance use history.
Yeah, important signs to watch for include them starting to hang out with peers who use, again, reporting intense cravings, stopping attending support meetings like AA or NA, having
Mhm.
trouble expressing their feelings honestly, or going through a major emotional crisis. These can all be red flags.
Wow, okay. That's a huge amount of ground we've covered. Taking a step back, what's the big takeaway message from this guide about pediatric mental health?
I think what really stands out is the sheer complexity we talked about at the beginning.
Yeah.
It's never simple, is it? It's
Mm.
always this dynamic interplay of genetics, brain function, life experiences, their environment.
Definitely complex. And the guide really hammers home the need for early identification, catching problems early, and a really thorough, holistic assessment, looking at the whole child, their whole world.
Right. And that multifaceted approach to care, using therapies, practical interventions, maybe medication sometimes, but always remembering that skills before pills idea.
And safety. That theme runs through everything, doesn't it? Assessing suicide risk directly, making inpatient units safe, recognizing abuse. It's about protecting these kids.
Yes, safety is fundamental.
Safety and I think compassion comes through strongly too. This material really underscores the need for compassionate, understanding care, and just unwavering support, not just for the child, but for their parents and caregivers too, who are going through so much.
Absolutely. It's a powerful reminder of the human element behind all these diagnoses and treatments. It's vital information for anyone working with or caring for kids.
Agreed. So here's a final thought for everyone listening, kind of building on that brain development point we discussed earlier. Given this guide mentions the adolescent brain is still developing until the early 20s and undergoes significant rewiring around puberty, how might really understanding the specific stages of that brain maturation process change how we approach both the diagnosis and the long-term treatment plans for mental health conditions that first show up during these really critical, really dynamic developmental windows? Definitely something to think about as you continue learning in this field.
Keep listening, keep learning. See you in the next one.